So hey everyone, welcome to Core, right? So let me start with the General Chemotherapy Part 2. Okay, so the very first term we are going to expose to, it's the minimum inhibitory concentration. So what does we mean particularly with the minimum inhibitory concentration? So without looking at the definition, let's just understand the concept first. Okay, so here it's a diagram for the serial dilution. I hope you had studied about the serial dilution in your microbiology, right? Okay, I'm not going to tell you about how to prepare this particular serial dilution. I just hope that you all know about the formation of the serial dilution. Okay, well, let's just tell you a brief. So you are going to add 9 ml of normal saline to the each test tube. Then you are going to transfer 1 ml of culture to the each test tube. Okay, 1 ml you are going to transfer 1 ml of the bacterial culture to the each test tube. Okay, likewise here we had added a 1 ml of the culture to the first test tube. Then from the first test tube we are going to transfer again and 1 ml. Then we are going to transfer again 1 ml to the next test tube and going to continue this process until the last test tube and discarding the last 1 ml from the last test tube. Okay, so that's how we are going to form a serial dilution. Okay, now after formation of a serial dilution, these are my test tube. Okay, let me draw first. So these are my test tubes. See, 10 to power 1 dilution, 10 to power 2 dilution, 10 to power 3 dilution, 10 to power 4 dilution, 10 to power 5 dilution, and at last 10 to power 6 dilution. Okay, so all these test tubes have a certain amount of culture in them, right? Now what I'm going to do, I'm going to add a certain antibiotic to all these test tubes. Okay, but the concentration for those antibiotic that I'm adding up to all the test tube is different. See, I'm adding in the first test tube I am adding 1 microgram of antibiotic. In second test tube I am adding 2 microgram of antibiotic. In third I am adding 3 microgram of antibiotic. In fourth 4 microgram. Say in the fifth 5 microgram, and in sixth 6 microgram of the drug. Okay, so I had formed a culture. In the culture we had 1 ml of the culture and with the serial dilution up to 10 to the power 6, right? Now after that what I did, I added up 1 microgram, 2 microgram, 3 microgram and consecutive up to the 6 microgram of the antibiotic according to the dilution level, right? Now after that I had incubated the test tube say for 24 hours. Okay, now after 24 hours what I observed that in the test tube which is having a dilution of 10 to the power 4. Okay, so the test tube that is having a dilution level of 10 to the power 4, what I saw, there was no visible growth of, say, the culture that I had inoculated was of streptococci. So the culture that was added is the streptococci. So in the test tube which is having a dilution level of 10 to the power 4, there was no visible growth for the strepto, right? So what I could just assume, so what conclusion what I could draw from here is in the test tube which was having a dilution level of 10 to the power 4, what was the amount of the drug? It was 4 microgram, right? So what I could conclude over here that this particular 4 microgram of the antibiotic, okay, so what I see that at the dilution level of 10 to the power 4, this particular amount of drug, which is the 4 microgram, is able to show what? An effect on the streptococci, from which we could see or from which we could observe that there was no visible growth. Means at that particular concentration of an antibiotic, there was no visible growth at a certain dilution level. That's what the minimum inhibitory concentration means. So let's go to the definition first. Okay, let's look for the definition. So it is the lowest concentration of a chemical, or which is usually a drug, which prevents the visible growth of a bacteria. See, that's what I taught you, right? In the dilution level, okay, we had prepared a dilution, then we had added a consecutive a different amount of drug into a successive dilution level, right? And after the incubation of 24 hours, what we saw that at the dilution level of 10 to the power 4, there was no visible growth. Okay, so what we can conclude that the minimum inhibitory concentration for the streptococci for a certain antibiotic was 4 microgram. Okay, so that concentration was the minimum inhibitory concentration for certain antibiotic. Okay, so this was about the minimum inhibitory concentration. Now it's not necessary that after increasing the concentration of a drug above MIC, means say the what we obtained was the 4 microgram was the MIC for a certain drug. It's not necessary if we give 5 microgram of that particular drug only for that susceptible bacteria. It's not necessary it will always show an effective response. Okay, it is not necessary it will always give a much more effective response towards that particular certain organism. Okay, it's not necessary. Okay, so you should remember that even increasing on the concentration with a several fold above the MIC, it does not significantly increase the rate of the microbial killing activity. Okay, so now there are two type of killing activity that a certain drug could show. Okay, there are two type of killing activity that a certain drug could show. One is the time dependent. Okay, second is the concentration dependent killing. Two type of activity a certain drug could show. What does this mean? See, from the name itself, it is clear that a drug, drug have two property. A drug could have a true property. Either it could be a time dependent killing, means if we expose, say, there are two bacteria, bacteria A, bacteria B. See, okay, there are two types of bacteria, bacteria A and bacteria B. Now what I did, say I had used the aminoglycoside as an antibiotic. Okay, now say we had used the beta-lactam. Okay, because beta-lactam show the time dependent killing. Okay, so what we did, we had exposed the bacteria A and bacteria B. Okay, from which antibiotic? From the beta-lactam. But I had exposed the bacteria A for 5 minutes towards the beta-lactam, and to the bacteria B I had exposed the beta-lactam for 6 minutes. So more effective response would be towards the bacteria B, more effective. Okay, why so? Because the beta-lactam showed time dependent killing. What does the time dependent killing means? Means if you increase the time of exposure of our drug, okay, if you are going to increase the time of exposure of a drug towards a bacteria or any microbe, then what it show more effective response. That's what the time dependent killing means. Now what does the concentration dependent means? See, again an example of two bacterias, bacteria A and bacteria B. And here's the antibiotic we could use is the aminoglycoside. Say I had applied the aminoglycoside on both the bacteria, right? But I had applied the antibiotic or the aminoglycoside at different concentration. See, I had used the aminoglycoside at a concentration of 6 microgram on bacteria A, but I had used the aminoglycoside at a concentration of 8 microgram on bacteria B. So the more effective response would be observed in the concentration of 8 microgram, because the aminoglycoside show the concentration dependent killing. What does it mean? Means when you increase the concentration of drug towards bacteria or any microbe, what does it show? It show more significant response. So that's what the concentration dependent killing means. Okay, now there are certain drugs that show the combination of both the property, means they show both time dependent and the concentration dependent. So example of those were the glycopeptides, okay, or the rifampin. Both are the example of the time and the concentration dependent killing. So here you can see that the drugs that show the time dependent killing are, it's the beta-lactam, it's the tetracycline, macrolides, nitrobenzenes derivative, and the glycopeptide. And the concentration dependent killing is shown by the aminoglycoside, fluoroquinolones, and the metronidazole. If we go with the both, which show the mixture of the both type of killing, it is the glycopeptide and the rifampin. And to some extent, the fluoroquinolones also show both the type of activity, which is the time dependent, means the increasing the exposure towards a drug, or the concentration dependent, means increasing the concentration of drug. Okay, so this was all about the time dependent, concentration dependent killing. Okay, now there is a post antibiotic effect, means say I had applied the aminoglycoside towards a bacteria. After a brief exposure of certain period, say 1 to 2 hour, okay, still the effect of the aminoglycoside will persist. Okay, after the brief exposure also, means a peak have been achieved by the aminoglycoside. After the brief exposure of that particular drug also, there would be a persistent effect. Okay, there would be a persistent effect of that particular antibiotic towards the susceptible bacteria, means a persistent of an antibiotic effect towards a bacteria even after the brief exposure, it's the post antibiotic effect. Okay, so you could just look by the definition also over here, that it is defined as the persistent suppression of a bacterial growth even after a brief exposure, say 1 to 2 hours, of a bacteria towards an antibiotic even in the absence of the host defense mechanism. So I had told you the concept and it is the definition, you can just look it by. Okay, now coming on to the side effects of the antimicrobial agents. So what kind of side effects it could show? Okay, so either the toxicity, there are certain side effects that we will discuss. So the first side effect is the toxicity. See, as I had told you that in the definition there was certain things that I had told you in the first lecture, that a drug is always a drug. Say there is a drug mentioned as A, so it would be more precise and more effective and more good, if you can say. Okay, it would be more good to use when it will show no or minimum adverse effect. So every time we give a drug to a patient, we always look for certain factors, that what is the condition of a particular patient is, because there are certain conditions towards which a certain antibiotic is producing a certain toxicity. Okay, so we should always analyze the patient first before prescribing any certain antimicrobial agent. Okay, such that there would be no or minimum adverse effect towards the host that is going to take up that certain antimicrobial agent. Okay, so what's the aim is? So the main aim of the usage of the antimicrobial agent is to prevent any adverse effect to the host that is going to take that particular antibiotic. Okay, so the first side effect is the toxicity. So there are two types of toxicity that a certain antimicrobial agent could show. One is the local toxicity and second is the systemic toxicity. So the local toxicity is what? See, sometime what happened, say this is my hand, okay, and you had applied an injection. Okay, you had applied an injection. So if there is a certain allergic reaction, okay, allergic reaction or any irritation at the site of application, means you had applied an injection on my hand. Okay, so at the site of the injection, what I felt, there was an allergic reaction. So if there is an allergic reaction, that what I felt at the site of the injection, so that particular type of toxicity is known as the local irritation or the local toxicity. Okay, so that what the local irritation means, right? Okay, so there may be formation of abscess at the intramuscular site where you had applied the injection, or there may be a thrombophlebitic. Okay, there may be a thrombophlebitic condition that could be produced during the IV administration of a certain drug, means intravenous administration of a certain drugs. So what and which classes of the antibiotic? There are several classes and there are few examples that I had mentioned over here, like erythromycin, tetracycline, cephalosporin and chloramphenicol show the local type of the irritation. Okay, now the systemic type of the toxicity, it is important because there are certain objective or the MCQ that come from this particular site. Okay, because they are going to ask you which particular antibiotic is going to show which kind of the toxicity. Okay, so all AMA have the dose dependent toxicity, means if you're going to increase the dosage of a particular antibiotic above the required level, means there is a certain, see, if a patient is going, okay, patient is coming to you and you know that a drug level of 5 microgram is enough to treat it. Okay, so the 5 microgram is enough to treat a certain patient, means the 5 microgram is going to treat a certain patient, it is enough to just kill that particular certain organism, but you are giving what, 100 microgram of the drug, so you are giving a 95 microgram extra, right? You're giving a certain amount of drug extra, so that particular extra drug will always lead to the toxicity. So it is always mentioned that a requirement of the drug should be equivalent, which is desirable. Okay, so there shouldn't be an usage of an excessive dose. Okay, so the dose should be such that it do not cause any toxicity. Okay, so there are certain drugs that have higher therapeutic index like penicillin, cephalosporin and erythromycin. There are drugs that are having the low therapeutic index like aminoglycoside, tetracycline and chloramphenicol. So aminoglycoside is going to show what, nephrotoxicity, ototoxicity by damaging the 8th cranial nerve. I'll discuss it later when I'm going to teach you the aminoglycoside. It is due to the presence of the phosphatidyl inositol. Okay, it is due to the phosphatidyl inositol, right? I'll discuss it later when I would be discussing about the aminoglycoside. Okay, so the tetracycline is liver toxic and the nephrotoxic. It shows the nephrotoxic and the hepatotoxic activity by damaging the liver and the kidney. And the chloramphenicol show the bone marrow suppression. Okay, coming on to the drugs that are showing very low therapeutic index, that are the polymyxin, vancomycin, amphotericin B. Okay, so the polymyxin B show the neurotoxicity and the renal toxicity. The vancomycin show the tendency to have a hearing loss and it is also nephrotoxic. The amphotericin B damage the kidney, the bone marrow and show also the neurological toxicity. So these drugs are used when you don't have any alternative to treat a certain patient. Okay, then only you are going to use these certain therapeutic agents, right? Now coming on to the second, which is the hypersensitivity. So there are certain drugs on application of which you can observe a certain hypersensitivity reactions, like in the application of the penicillin, cephalosporin, sulfonamides and the fluoroquinolones, there is an allergic reaction or an anaphylactic shock could be there. There could be rashes. Okay, so these hypersensitivity reactions could be produced after the application of a certain drug like the penicillin, cephalosporin, sulfonamide and the fluoroquinolones. Okay, so coming on to the third, which is the drug resistance. So what does the meaning of the drug resistant? It's clear with the name itself that a bacteria or a microbe is going to resist any response towards any antimicrobial agent. For an example, there was a bacteria namely A. Okay, it is not going to show any response towards an, say, antimicrobial agent. So for an example, aminoglycoside, we are going to apply aminoglycoside on a certain bacteria namely A. So it is not going to entertain that particular aminoglycoside. It will say, go fuck yourself, I'm not going to take care of you. Okay, I'm not going to show any response toward you. You're not able to damage me. Okay, that's what the bacteria A is going to teach to that aminoglycoside, right? It is not going to show any certain response towards this aminoglycoside, right? It is not going to entertain that certain aminoglycoside, means it is going to show an unresponsive effect. Okay, so that particular unresponsive effect of a microbe towards any antimicrobial agent is namely termed as drug resistant. So there are certain types of drug resistant that could be acquired by a certain bacteria. So either the drug resistant could be natural, means by birth I had that particular ability that I could resist any antimicrobial agent. For an example, the penicillin is naturally resistant towards the gram negative bacilli. Okay, it is not, the gram-negative bacilli aren't going to entertain the penicillin. Okay, because penicillin is not effective towards the gram-negative bacilli. Okay, so in the aerobics, the metronidazole is ineffective. Means if you are going to apply metronidazole on the aerobic organism, it is not going to be an effective choice of drug. Okay. Similarly, the anaerobics are not inhibited by the aminoglycoside. So the aminoglycoside is also not able to treat the patient, because for an aminoglycoside to be show an effective mode of action, the presence of oxygen is necessary. That's why the anaerobics can't be inhibited by the aminoglycoside. Okay, and the mycobacterium tuberculosis is also insensitive towards the tetracycline. Okay, that was about the natural resistant. Now coming on to the acquired resistance. What does the acquired resistance mean? So the resistance which is due to the longer exposure towards a certain antimicrobial agent, means these resistance are acquired by a certain bacteria over a lifetime. Means over the generations, due to the excessive exposure of a certain antimicrobial agent, what is there that a certain bacteria is going to acquire a certain resistance, right? So it could be from various types, like the mutation. A bacteria could just mutate itself. Okay, it is a vertical transfer of the resistance. Okay, it could be due to the single step or the multiple step mutation. Okay, so these are the example of the single step and the multiple step. Okay, you can watch out over here that the enterococci is resistance towards the streptomycin due to the single step mutation, and staph and E. coli are resistant to the rifampin due to the single step mutation, right? Similarly, for the multiple step mutation, there is an example that the several microbes have resistance towards the erythromycin, tetracycline, and chloramphenicol. Okay, now coming on to the gene transfer, means in the acquired there were two. Okay, first one was your what? Mutation. Second is the gene transfer, which is the horizontal transfer of the resistance. The mutation was what? The vertical transfer. The gene transfer is the horizontal transfer. Okay, so there are three types, the transfer you had studied in the microbiology, that could be three types of the gene transfer, either the conjugation, transduction, and the transformation. Okay, so you can just see over here what is the transformation. You know that you're going to make susceptible the boundaries or the cell wall of a certain bacteria, such that the plasmid that is there in the surrounding, it's going to incorporate in the bacteria. That's what the transformation means. Okay, so the transduction is held by the usage of the bacteriophage. Means the bacteriophage is going to carry a certain resistant gene which is going to be inoculated or just injected inside the bacteria, such that the resistant could be acquired. That's what the transduction mean. Okay, what's the conjugation means? Conjugation means that, say, this is the A, this is the B. Okay, A bacteria, B bacteria. A bacteria have a certain resistant factor. Okay, so this particular resistant factor gene is going to be transferred to the bacteria B via the usage of a sex pilus. Okay, so this particular sex pilus would be allowing the resistant factor to just get it transferred to the bacteria B. That's what the conjugation means. So these all three are what? Gene transfer mechanism of resistance, or the horizontal resistance, right? I hope this is clear. Okay, now there is another thing to resist towards any antimicrobial agent, either by the drug tolerant, either by the drug destroying ability of a certain microbe, or by having a drug impermeability. What does that mean? Okay, so certain bacteria or certain microbes are tolerant towards a certain antibiotic. Likewise, means they are tolerant, they aren't going to be effective. Okay, so the drugs aren't going to be effective towards a certain microbe. That's what the mean is, that a drug is tolerated by a certain microbe. That's what the drug tolerant abilities means. Okay, so the staph and the E. coli developed an RNA polymerase that don't bind to the rifampin. Means the rifampin have a tendency to bind on the RNA polymerase. Okay, so what the staph and E. coli did, they developed a certain RNA polymerase that is not going to be affected by the rifampin. Okay, similarly, the penicillin binding protein is altered by the pneumococcal strain. See, the penicillin, if we when we are going to learn about the penicillin, or when I will be teaching about the penicillin, you'll see that the penicillin, the mode of action of the penicillin is by attaching at the penicillin binding protein. So what happened, that certain pneumococcal strain, what they did, they developed a different, or they show an alteration on the penicillin binding protein, such that the penicillin don't have the ability to attach on the particular organism and show the effective response, right? So that's what the penicillin binding protein means. That's how the drug is going to be tolerated by the pneumococcal strain. Means they are going to alter the penicillin binding protein that has there been in the surface of the pneumococcal bacteria, right? Now coming on to the next, that is the formation of the dihydrofolate reductase, which have low affinity towards the trimethoprim. When you are going to study the sulfonamide, you will see that in the sulfonamide and the trimethoprim, both are having the ability to inhibit the folic acid synthesis. So what does the trimethoprim do? It inhibits the dihydrofolate reductase. Okay, so it inhibits the dihydrofolate reductase. Okay, but what happens, certain bacteria, what they did, they will develop a certain dihydrofolate reductase that have low affinity towards the trimethoprim. So if a drug is having a low affinity towards a dihydrofolate, so that means, oh, if a bacteria is going to have a low affinity towards the dihydrofolate, so what reductase, so what is going to happen? It won't show any response towards the trimethoprim. Means the trimethoprim won't be able to just inhibit that particular folic acid synthesis, right? Now coming on to the drug destroying property of a certain organism. So what happened, that certain organism have a certain enzymes which are going to just inactivate the drug. Okay, likewise the penicillin is going to be inactivated by the beta lactamase and the penicillinase. Okay, so these are the two enzymes that have the ability to inactivate the penicillin. Okay, these are produced by the staph, haemophilus and the gonococci. And there are certain enzymes also, like what, the chloramphenicol acetyltransferase, that are produced by what, the E. coli, influenza bacteria and the typhi. Okay, so what they are going to do, they will go and inactivate the chloramphenicol, right? There is also aminoglycoside acetyl transferase. Okay, that particular aminoglycoside acetyl transferase will going to inactivate aminoglycoside. Okay, these are the example of the drug destroying property of a certain bacteria to have a resistance towards the antimicrobial agent. So there are certain bacteria that will make the impermeable cell membrane such that the drug couldn't pass. That what means by the drug impermeability, that the drug isn't allowed to enter the bacteria. If the drug isn't allowed to enter the bacteria, it won't be showing any effective response, right? So that's what the drug impermeability means. Now coming on to the cross resistance. Okay, so what does the cross resistance means? For an example, there is aminoglycoside. Okay, there is a class of drug which is aminoglycoside. It is having what, say we are taking an example of two example, that there is streptomycin in the aminoglycoside and there is amikacin. Both belong to the class aminoglycoside. So which is A, right? Now I had exposed that particular bacteria towards the streptomycin. Okay, when I had exposed a certain bacteria towards the streptomycin, what happened next time when I had exposed the same bacteria towards the, and it had gone with the resistant. Okay, it had developed a resistant towards the streptomycin, right? When I had applied the streptomycin, the bacteria A had gained the resistance towards the streptomycin. Now what happened when in the next time I had given the amikacin to the same A bacteria, what I saw, there was no response. Why there was no response? Because as I had told you that both the drug belong to what? Aminoglycoside, right? Both the drug belong to the series of aminoglycoside. Now what is happening when I had applied the streptomycin on the very first time towards the bacteria A? Okay, now what happened that the bacteria had gained a resistance towards that particular drug, right? Now what happened when in the next time I had applied the amikacin, which is of the same class, right? Same class, which is the aminoglycoside. Now what happened when I had given the amikacin to that particular A bacteria? There was what I observed, there was no response that has been produced. Why? Because there was the cross resistance. Means on the application of a certain drugs, okay, the microbe has attained to an resistance affinity towards any other drug. Okay, that's what the cross resistance means the acquisition of the resistance to one antimicrobial agent conferring resistance to another microbial agent, okay, to which the organism hasn't been exposed. Means I haven't used amikacin earlier, but when I used the amikacin, what I observed that there wasn't any response. So that's what the meaning of the cross resistance means I haven't used any drug, okay, earlier on the bacteria, but when I had used that particular drug, what I saw, there was no response due to the development of the resistance towards that particular antimicrobial agent जिसको मैंने कभी यूज ही नहीं किया, उसके टुवर्ड्स भी रेजिस्टेंस डेवलप हो चुकी है. Okay, so that what's the cross resistance means. Okay, now there could be a one-way cross resistance or two-way cross resistance. Okay, so there could be intragroup and intergroup. Intragroup means like aminoglycoside have streptomycin and amikacin. Okay, both belong to the same group. If the cross resistance has been developed in the same group, that is known as the intragroup. Okay, if the cross resistance has been developed between intergroup, means different classes of the drug. Likewise, resistance between the erythromycin, which is a macrolide. Okay, erythromycin belongs to the class macrolide, while the clindamycin belongs to the class lincosamide, right? So if the resistance is developed between the erythromycin and the clindamycin, vice versa, so both are of the different group. So what does it mean? It means the resistance that has been developed is the intergroup resistance. Okay, now there are certain terms again like supra-infection. So it is what? It is the appearance of the new infection as a result of an antimicrobial therapy. Means when you are going to apply a certain antimicrobial agent on a certain host, what happened? There is an appearance of a certain new infection as a response towards this particular agent that you had applied on the host. Okay, as the AMA makes certain alteration in the microflora of the animal. Okay, so when there would be an alteration in the microflora of an any sort of animal, means it is going to suppress that particular microflora inside your body. So it will obviously lead to an exposure of the new infections, right? Okay, so the common problem, it is the super infection or the supra infection is generally seen with the broad spectrum antibiotics. Okay, because they are going to just show the effects. Okay, it is a common problem with the broad spectrum, the super infections, right? Now coming on to the masking of the infections, means when you are going to apply a certain antimicrobial agent, what it will do, it would suppress a certain microorganism, but simultaneously it will going to just suppress or mask the effect of another microbe also. Means, for an example, the penicillin, we had given the penicillin for gonorrhea. Okay, but what the penicillin did, the penicillin also masked the effect of what? The syphilis. Okay, so that's what the masking of infection means. So the short course use of any antimicrobial agent may be sufficient to treat one infection. Means it may treat the gonorrhea. Means the penicillin is going to treat the gonorrhea, but only briefly suppress another one contracted currently. Okay, it is going to suppress syphilis. Okay, now the factors that affect the choice of the antimicrobial agent, means what are the factors that are going to affect the choice of the antimicrobial agent. Means as I had told you earlier, that you aren't going to use any antimicrobial agent on any host, because the physiological condition of the host that you are going to provide with any microbial agent varies. Okay, physiological condition of each host varies. So the choice of antimicrobial agent should be changed according to the condition that a patient has having, right? So there are three types of the factors that affects the choice of any antimicrobial agent. Means the factors that are going to affect the choosing of any antimicrobial agent. You can't prescribe tetracycline to a patient which is having a liver damage. Okay, if a patient is having a hepatotoxicity or it is having a liver damage, you can't just prescribe tetracycline with an excessive dose. Okay, because it will further aggravating the condition, right? So there are three type of factor: the host related factor, the organism related factor, and the drug related factor. So the host related factor is, first one is the age. Okay, so the newborn, obviously the newborn don't have that much capability to just metabolize all the drug. Okay, it don't have the capability to metabolize all the drug, because the liver isn't that much developed, the kidney isn't that much developed to just process that particular drug. Okay, so in newborn there are certain drugs that show toxicity. Likewise, the chloramphenicol show toxicity in the newborn and going to produce what, the gray baby syndrome, right? Similarly, the sulfonamide displays the bilirubin, okay, which is leading to the carniacterus. It is an condition that is produced by the sulfonamide use. Okay, it is an age related factors, right? It is a host related factor, to be precise. Likewise, the T half of aminoglycoside is prolonging in an elder can damage the eighth cranial nerve. Means the increase in the T half means the half life of the aminoglycoside. If it's going to increase, what it could lead to? It could lead to the damage of the eighth cranial nerve. Okay, now coming on to the next, which is the tetracycline. So the tetracycline deposition in the developing teeth and bone cause the discoloration. Okay, so this was the host related factor which we are continuing. So they are, as I had mentioned, the renal and the hepatic toxicity. Okay, if the kidney and the liver isn't functioning well, so you should always look for whether the patient have a history of a liver damage or the kidney damage. If the patient is having the history of a liver or a kidney damage, then you have to choose a certain microbial agent which is not going to create an aggravating situation or just going to damage that particular kidney or liver of that particular susceptible host. Okay, because the kidney and the liver is already damaged earlier. If you are going to give the drug that is hepatotoxic, that is nephrotoxic, then obviously it is going to just again going to aggravate the condition. That's what the renal and the hepatic function you should look for, right? So in the mild renal failure and the mild hepatic failure, in the mild renal failure, what you should do, you should reduce the doses of these following drugs that I had mentioned. In moderate, you should reduce these following drugs, right? And the drugs that should be avoided in the renal failure are these. Okay, so in the mild renal failure, what you could do, you can just reduce the dosage of the aminoglycosides, cephalosporin, amphotericin B, etc., right? In the moderate to severe renal failure, what you could do, you could just reduce the usage of these drugs, or you could just reduce the dosage of these drugs. Okay, the drugs that should be avoided in the renal failure are tetracycline, nitrofurantoin, nalidixic acid, and the telampicillin, right? In the hepatic failure means the liver is damaged. Okay, so which drug you should reduce and which drug should be avoided? So whenever the patient history is with the liver damage or the liver failure is there with the patient, then the drugs which you should avoid are the erythromycin, tetracycline, pyrazinamide, nalidixic acid, telampicillin, and the pafloxacin, right? And the drug which can be used but with the reduced dosage. Okay, so in hepatic failure, you could use chloramphenicol, isoniazid, metronidazole, rifampin, and clindamycin, but with the reduced dosage, right? Hope it is clear. Moving forward with the local factors. So what are the local factors? See, the application of the any antimicrobial agent is also dependent on the local factors. So what kind of local factors are? See, whenever there is a pus condition, okay, if there is a pus condition or a secretion condition, so what the pus and the secretion do, it will just reduce the activity of the sulfonamide and the aminoglycoside. So the usage of aminoglycoside and sulfonamide should be looked before if there is a pus condition or there is a secretion condition. So what happens that this particular condition will reduce the efficacy and the efficiency of the sulfonamide and the aminoglycoside. Similarly, the tetracycline, penicillin, and cephalosporin bind to the degraded hemoglobin in an hematoma. Okay, so whenever there is a condition of the hematoma, you should look for first and then apply certain drug, because tetracycline, penicillin, and cephalosporin aren't effective in the condition of the hematoma. Okay, certain drugs are effective at certain pH, certain drugs are effective at high pH, certain drugs are effective at low pH. Okay, so you should also look for the pH effectivity, right? pH activity is also very much important factor that you should look for. Okay, so at low pH, the activity of the macrolides and the aminoglycoside is reduced. Okay, in the inflammatory conditions like subacute bacterial endocarditis, SABE, which is, or the endophthalmitis or the prostatitis, it hampers the access of the AMI to that sites, right? So the inflammatory condition do affect the efficacy, efficiency, or the activity of any certain drug, right? So there is drug allergy also. The beta-lactam, sulfonamides, fluoroquinolones all show the drug allergy. Okay, certain amount of drug allergy is shown by them. Okay, so the impaired host defense also an important factor while using or while choosing a certain antimicrobial agent. Okay, so the in the pregnancy, maximum of the drug should be avoided because they may show any adverse effect to the fetus also. So in pregnancy, all AMA are generally avoided, but there are certain antimicrobial agents that could be used like penicillin, erythromycin, and the cephalosporin. Okay, these all three are pregnancy safe, right? There is also genetic factor, like there are certain patients which are 6PD G6PD deficit, right? So in those patients, the primaquine, nitrofurantoin, sulfonamide, chloramphenicol, and the fluoroquinolones have risk to produce a hemolysis. Okay, means these on the application of these drugs, it may lead to hemolysis in the patient which are 6 G6PD deficit, right? Now there are organism related consideration that you should look for. So what happened? See, in the organism, if you are going to use the broad spectrum, okay, you could use the broad spectrum when you don't have any report. See, if you know that the organism is gram positive, so you could use a narrow spectrum antibiotic towards that particular gram positive bacteria, right? But if you don't know that infection is due to the gram positive or the gram negative, that then you should use a broad spectrum antibiotic, because the broad spectrum antibiotic is going to affect both type of the bacteria, the gram negative and the gram positive. Okay, in that condition you could just use the broad spectrum antibiotic. If you have a report that yeah, this particular organism is gram positive, then you can use a gram positive specific drug. Likewise, the penicillin is effective towards the gram positive. Then if you have a report that yeah, this particular patient is affected due to a gram positive bacteria, then obviously you could use a specific drug which is affected towards the gram positive. Okay, that's what's the organism related consideration that you should look for. Now the last is the drug factor. Okay, so obviously you should always prefer narrow spectrum over the broad spectrum due to the resistance that may develop. Okay, resistance should we avoid the development of resistance, right? We avoid always the development of the resistance, so that's why we always use narrow spectrum over the broad spectrum. Okay, and always we prefer the cidal activity of a drug over the static activity. We always prefer to just kill the certain microbe. Okay, we always prefer the killing of a microbe rather than stopping its growth. Okay, so we always prefer the drug should be having a sidal effect rather than a static effect, right? Now you should always assess the MIC value. The minimum inhibitory concentration should be assessed before the application of a certain drug. Okay. Now relative toxicity. Okay. What happened that you know that we are going to treat a certain, say you are going to treat a gram-positive bacteria. Okay. You can apply the penicillin, you can apply the aminoglycoside. But we know that the aminoglycoside have more toxicity as compared to the penicillin. Okay, so we always prefer penicillin over the aminoglycoside. Okay, so that's what the relative toxicity means. Means we are going to choose a less toxic drug. Okay, a less toxic drug is always preferred over the higher toxic drug. Okay, now you should also focus on the pharmacokinetic profile of a certain drug. Okay, whether it is, what property does it carry about the pharmacokinetics, right? Likewise, fluorochenols have the excellent tissue penetration. Okay, ciprofloxacin and rifampin have good intracellular penetration. Ampicillin, cephalosporin, erythromycin attain high biliary concentration. Okay, these all drugs are showing certain different responses based on their pharmacokinetic property, right? So the chloramphenicol, ciprofloxacin, cefuroxime, ceftriaxone attain the higher concentration at the CSF. Okay, so in the cerebrospinal fluid, the higher concentration of the chloramphenicol, ciprofloxacin, cefuroxime, and ceftriaxone is attained higher concentration. They are going to attain a higher concentration in the CSF, cerebrospinal fluid, right? So in the penicillin and the aminoglycoside, they are going to penetrate the CSF poorly. Means they are going to penetrate the cerebrospinal fluid effectively, right? So if you are going to treat a certain patient which is having any issue in its cerebrospinal fluid, you're targeting the cerebrospinal fluid, so obviously you're going to prefer chloramphenicol and your ciprofloxacin, cefuroxime over the penicillin and the aminoglycoside. Why so? Because the penicillin and the aminoglycoside show poor penetration in the CSF. Okay, now there is certain thing that the combined usage of the antimicrobial agent. What we do whenever you are going to any medical shop, you can see the drug. Nowadays the drug you are using, they aren't the composition. If you go and see the composition of drug, okay, the drug that you are taking, it is not the use of single drug. Okay, we do not use the single drug to treat a patient, right? We always use multiple, maximum in the cases we always use multiple drugs, right? There is a combination of drugs while using when you are going to formulate a drug, we use multiple drugs. Okay, we use multiple kind of drugs to formulate a drug, right? Likewise, for an example, you can add penicillin with cephalosporin, right? You can add penicillin and the cephalosporin. Why so? Why you are going to add two classes of the drug? Why you are going to add two classes? The reason is there to achieve synergism, to reduce the adverse effect of a certain drug, to prevent the emergence of a resistance, and to broaden the antimicrobial spectrum. Okay, so what happened when you are, for an example, let me take an example. We know that there is sulfonamide, okay, and there is trimethoprim. Okay, why we use both of the drug together? Because the sulfonamide inhibit other enzyme, the trimethoprim inhibit other enzyme, but both inhibit the enzymes in the same folic acid synthesis, right? So they are in folic acid synthesis, there are several enzymes that are there, right? So but In the folic acid synthesis, there are separate enzymes acting on the different steps, right? But the sulfonamide is going to affect another enzyme, and the trimethoprim is going to affect another enzyme. Okay, now what we are going to do, we are going to just sum up the properties of the trimethoprim and the sulfonamide in order to inhibit both the enzyme. Earlier, what we are going to do, if we are going to use the sulfonamide alone, it is going to inhibit only a single enzyme, right, in the folic acid synthesis. But if we use the combination of the sulfonamide and the trimethoprim, it is going to inhibit two enzymes, right? If the two enzymes are going to be inhibited, it will give a synergistic effect. Okay, there would be a synergistic effect for both the drugs, right? So the composition could have a sulfonamide and a trimethoprim. Why it is going to have a, it is going to give a good response. It is going to give a synergistic response, to be precise, right? It is going to give a synergistic response, right? And what happened also, see, if you are going to use a drug alone, if you are going to use sulfonamide alone, obviously there are chances that a bacteria or a microbe could get a resistance towards that particular drug. But if you are going to give a combination of drugs, right, then what will happen, there is a less chance to develop for a development of a resistance towards a certain antimicrobial agent. That's why also we use the combination of the drug. Okay, so that these are the combined usage of the antimicrobial agent, why we prefer to use to combine certain antimicrobial agent. Likewise, I had given an example for sulfonamide and the trimethoprim. What happened? The sulfonamide inhibit another enzyme in the folic acid synthesis. The trimethoprim inhibits separate enzyme in the folic acid synthesis. But when we are going to use these two drugs, both are going to combine. Both are going to combine and give a synergistic effect, right? Both are going to give a synergistic effect, right? And both are, when we are going to use both the drugs, they are going to what? They are going to just, there would be reduction in the dosage also, right? There would be reduction of the dosage also, right? When we are going to use sulfonamide alone, say we are going to use 10 microgram of the sulfonamide. But when we are going to use sulfonamide plus trimethoprim, so we could use just 5 microgram of the trimethoprim. I'm just giving an example of a formulation. It's just an example. It's not an actuality. Okay, so what we can do, just sulfonamide that was earlier used at the rate of 10 microgram. It is now used at the rate of 5 microgram when it is going to be combined with the trimethoprim, right? Understanding the concept that earlier we are going to use the sulfonamide at a higher dose rate, but now we can see that there is a reduction of the dose also. So it will decrease the chances of resistance development, right? That is also the use of the combined usage of the drugs, right? When you are going to combine the antimicrobial agent, these following things you can achieve, right? The adverse effect could be reduced by the usage of the combined effect, right? You can get an synergistic effect. The emergence of the resistance could be avoided, right? The spectrum could be broadened, right? These are the combined usage of the antimicrobial agent. So here you can see that what happened to achieve the synergism. What happened that to decrease the MIC of one AMA in the presence of another AMA. That's the similar thing I told you, that earlier the sulfona was used at the rate of the 10 microgram. But when I had used the combination of the sulfonamide and the trimethoprim, so the sulfonamide is used at the dose rate of the 5 microgram and the trimethoprim is used at the rate of the 5 microgram. Okay, so it's just an example, it's not an actuality of the formulation. Okay, so the MIC of each drug, if it is reduced to 25%, it is termed as synergistic effect. If the MIC of each antimicrobial agent that you had used in the combination, if it is reduced to the 25 to 50%, it shows an additive effect. Okay, if the MIC of each drug that you had used in the combination or the composition of a drug, which is more than 50%, then it indicate the antagonism, right? Now coming on to this usage of the two bacteriostatics, say. Now, there I had told you in the first lecture of the general chemotherapy, there are certain drugs that are bacteriostatic and there are drugs that are bactericidal, right? If you're going to combine two bacteriostatic drugs, so the additive effect could be shown and really synergistic effect we could observe. Likewise, the example of the sulfonamide and the trimethoprim, which cause the sequential blockade in the folate metabolism or the folic acid synthesis in the bacteria, right? Tetracycline, chloramphenicol, and erythromycin could be combined together, right? Now, when you are going to combine two bactericidal drugs, okay, then they could be frequently additive and sometimes they show the synergistic effect. Likewise, in the treatment of the tuberculosis, for the first line, what was the first line of treatment for the treatment of the tuberculosis? It's the combination of the drug, which is the rifampicin or the rifampin in the combination with the isoniacids, right? The penicillin and the streptomycin is an aminoglycoside, right? And the penicillin belongs to the beta lactam, right? So these are combined together for the treatment of the enterococcal SABE, right? Now the penicillin affects the cell wall synthesis and the aminoglycoside enters the bacteria, right? What's the aminoglycoside do? It causes the misreading of mRNA. Okay, I had told you earlier also, it causes the misreading of mRNA. So the penicillin is inhibiting the cell wall synthesis, while the aminoglycoside is going to just what? It is going to just misread the mRNA, that is going to stop the protein synthesis, right? Now we can also, there are three type of combination that we can see. Okay, the first is the combination of two bacteriostatic drug. The second we see was the combination of two bactericidal drug, right? The penicillin or the beta lactam and the aminoglycoside, both are what? The bactericidal drug. Okay, now you are going to combine the penicillin and the aminoglycoside in order to achieve a synergistic effect, okay, in order to reduce the toxicity, in order to reduction in the development of a resistance, right? Now, the third possibility in the combination could be the combination of a bactericidal and a bacteriostatic drug. It may be synergistic or it may be antagonistic. Okay, so when you combine penicillin, which is an bactericidal, and when you are going to combine it with a tetracycline, when penicillin, which is a bactericidal, and when you are going to combine it with a tetracycline, which is bacteriostatic, it could be used for the treatment of the pneumococci, right? It could be used for the treatment of the pneumococci. When penicillin and the sulfonamide, where penicillin is a bactericidal drug and the sulfonamide is a bacteriostatic drug, it could be used for the treatment of the actinomycosis, right? Streptomycin, which is an aminoglycoside, tetracycline, which is a bacteriostatic drug, it could be treatment in the brucellosis condition. Means in the treatment of the brucella, you could use the aminoglycoside, which is the streptomycin. You can consider it streptomycin, and the tetracycline for the treatment of the brucellosis. Now, rifampicin and the dapsone. Dapsone is belonging to the class of the sulfonamide also. Okay, dapsone is a bacteriostatic. It's came under the your sulfonamide also, and the rifampin is in bactericidal. Okay, it is in cidal drug, and dapsone is in bacteriostatic. So these both can be used in the treatment of the leprosy. So that's how you are going to combine. See, obviously, if you are going to make a certain construction work, so you are going to form a pyramid, right? If a single person will form a pyramid, it will take much time, right? If two person are going to form the pyramid, it would be more efficient, right? So similarly, when you are going to prescribe a certain drug to any individual, so the composition that we always form is the combination of many drugs, right? Why we are going to combine many drugs? Because these are the four reasons: to achieve synergism, to reduce the adverse effect, to prevent the emergence of the resistance towards a certain antimicrobial agent. Because we are going to just reduce the dosage of a certain drug. If there is a reduction in the certain drug, obviously the chances of development of a resistance reduce, right? And the last, we want to what? We want to just broaden the spectrum. Okay, So that was, I guess, all about for the today's lecture. So thank you everyone. Have a nice day.